I'm the screen sharing is not making itself apparent to me. Do I have ability?
It's up there on the top right by the leave button. There's that little box with an arrow in it.
Yeah, my little box with the arrow takes me to something.
It should then pop up and then give you the different options on the screens to share.
It's not. Okay, maybe recording. Can you guys see that?
You got it.
Okay. Well, now my screen is not there. Okay, as long as you can see, I'm gonna let you guys tell me if there's a problem, because all I see are my slides.
We see you and we see your slides. So
Okay.
That's a good. Dr. Sanchez, if you could turn your video off, that would be great.
Okay, so we talked a little bit about the audits. Predominantly right now, what we have going on are Medicare administrative contractors, which we use the term MAC to describe. Those are the folks that pay the bills for the providers. They're conducting both prepayment and post-payment reviews. We keep getting notifications, hey, reviews are back. Hey, reviews are back. So post-pandemic, we're back to pre-pandemic state, apparently. No more waiting until the end of the public health emergency to get back into the saddle of ensuring that proper payment is made and improper payments are not made. Essentially, the Medicare administrative contractors are looking at your documentation for whether or not the patient's stay was reasonable and necessary. Now, I'm talking mostly here about inpatient rehab. These concepts, of course, do cross over to every level of care. So if you're doing consults in the acute care hospital, they're looking at the establishment of reasonable and necessary for those patients as well. Those are not typically the types of reviews that are happening in the acute care setting. The types of reviews are more around whether or not the patient should have been admitted versus stayed an observation patient. In the skilled nursing setting, they are looking for reasonable and necessary. So everything we touch on will have the same application to that setting as well. Also true for the LTAC setting. The unfortunate part of a term like reasonable and necessary is it's really hard to put your finger on what they mean. There's not any sort of recipe for how to document for reasonable and necessary. What we're trying to show is that the patient's needs could only be met through the services provided in an inpatient setting. That as far as inpatient rehab goes, they needed hospital level of care. I did a presentation earlier this week for a large group of inpatient rehab providers, and we were talking in that presentation about the satisfying that need for why are you admitting certain patients, and what is the differentiation for us between inpatient rehab and skilled nursing, and how do we convey that? Because a lot of times that's the biggest competition for an inpatient rehab provider is the skilled nursing facilities in that area. So how do you know how to talk to case managers and other physicians sending referrals to inpatient rehab that's the right setting? And in my mind, I always try to think about and thus convey through documentation on the other end that the patient needed to be in the hospital. They needed close medical supervision and close nursing supervision. They're going to get therapy just about anywhere they go in the post-acute continuum. Granted, we're going to have different amounts of therapy and different levels of therapy. But in my opinion, the real differentiation is how much work the physician needs to do to make sure that patient stays medically stable. And then the role of the nurse is following through on the orders as written by the physician, doing their assessments and ensuring that the patient does stay safe through their monitoring and management. The other thing that we use to prove the necessity is the patient could not make significant improvement without the intense rehab services. I've had a really long, didn't we all have a really long 2020, but I got to experience the need for inpatient rehab through an illness that my father was dealing with. And I'll tell you, the value of the services of being in an intense program, going beyond just the 3 hours of therapy a day to the fact that the entire team is working toward the same efforts, is a huge benefit. And that when he didn't have it because of radiation therapy that was going on, the first go round when he really needed it versus the time that he wasn't getting radiation, so he was considered a candidate for inpatient rehab, the outcomes were huge. The burden on me at the end of my dad's hospitalization was huge the first time and not so bad the second time. So we are showing that the patient can make significant improvement. That does take some thinking through the case, which you're doing on a pre-admission level, to indicate whether or not you feel that patient does have the potential to make significant improvement. So our documentation may show it through the stay, and that's vastly important, but we have to also remember we're establishing the fact that the patient needs a certain level of hospital care, and we believe that that hospital care will make a significant difference for that patient. So it starts with the pre-admission screening, it's further established through your H&P, and then we build on that through the rest of the patient's stay. This criteria is very old. I believe in the beginning of rehab times, back in the 80s, this criteria was established. It remains in place and it's used in a variety of different ways now. It used to be the only thing we thought about in terms of documentation. And when I did presentations prior to 2010, these were the things that I talked to providers about including in the documentation. Now we go beyond this for inpatient rehab to the certain timeframes and guidelines that CMS put in place in 2010. But these 7 pillars of our documentation remain as the most important parts. So if you looked at the CMS paperwork that's required for a rehab facility to get up and running, the documentation focuses on these 7 things: that you provide these services and that you're admitting patients who need these services, and that your documentation conveys that, because during the CMS survey, they actually are looking at the charts to show that you're demonstrating adherence to these 7 criteria. I mentioned that there are a multitude of ways we're using this criteria. That's number 1. Number 2, you're using this criteria when your liaisons are out in the field evaluating patients for their ability or need to come to rehab. So as you physicians and extenders are reviewing pre-admission screenings, you're looking for these things. Does the patient require medical supervision? Do they need 24-hour rehab nursing because there are things going on with the patient that means they're not going to be potentially stable throughout the day and will need different care from morning to night, or at least close management and monitoring through the night. Intense level of services, which is our therapy services and our 3-hour rule, an interdisciplinary approach to care. So they're going to be better off because their PT is teaching something that is carried over by nursing, by OT, by any other provider. The CNA is working with the patient. Vice versa with the nursing, the things that they're watching very closely with bladder and bowel management, teaching a bladder or bowel program should be carried over into the therapy hours. So if the patient needs to go to the restroom or it's their Q2 hour toileting time, the therapist adheres to that as well. So we're working together to make sure that in a coordinated manner, we're giving the patient everything they need throughout the day. The significant practical improvement means that the patients admitted to the inpatient rehab setting have the potential to get better. It's not always about their scores. In the world of FIM scores, for those of you that were around in that time, we did talk about where they were at admission and where they were at discharge, and FIM change was one of the ways that we could demonstrate significant practical improvement. We have a new tool with the section GG items on the IRF-PI that's also being used in the LTAC setting on the care data set and on the MDS in the SNF world. So at least we have uniformity with this new tool. One of the things we lost with that is, I believe, some specificity to identify the patient's level, particularly when they're max assist to mod/min assist. We don't have enough numbers to characterize really small improvements that may mean a lot. So now significant practical improvement is more qualitative than it is quantitative. That was always true in cases of complete spinal cord patients that may not move the needle on a FIM number. They also may not move the needle on a section GG functional score. But what they gain from an inpatient rehab setting is huge and will have significant impact in their ability to function outside of the rehab setting. So we do want to convey that we see the potential for that on the pre-admission side. Of course, that's also going to filter through the documentation during the stay. And we want to be able to set realistic goals for the patient. So, if they're coming in at a supervision level, it's kind of hard to say you're going to have realistic goals for significant improvement. If they're coming in at a totally dependent level, we certainly don't want to be setting goals for independence. They're not going to make it that far in the amount of time that we have. So the goals that are established on the pre-admission screening and then during the stay ought to be a good reflection of what we think the patient's capable of achieving. The last way we use this criteria or see this criteria used is in post-payment reviews. So when a CMS auditor, whatever form they take, requests charts, they're looking for proof of the need for the post-acute stay by looking for demonstration of these 7 things. So how do we document that? We need to show complexity. We need to show that a licensed clinician is needed. And that's really the PT and OT piece of this, that the therapists need to be at a certain level where the patient's care plan requires their interaction or input rather than being able to use a CNA or a therapy tech to run through a patient's program with them. We need to show that the patient needs to be in an inpatient setting. To me, that means that, when they first get there, you're still managing things medically. They're not stable. If they were stable enough to go home, we should have been sending them home. So I don't believe that a patient should be expected to have medical instability every day of their inpatient rehab stay. That's not the way it happens. You don't get them better and then send them home the next day. You get them better, you watch them to make sure that they are better. And honestly, in a typical 14 to 21 day stay, and most average is 14 days, the patient's going to have more things going on in the beginning that require medical intervention, where during the stay, some of those medical needs ought to become more stable. And you're moving on to being able to educate the patient and family on how to manage these conditions. You're moving on to more intensive therapy and being able to do more now that potentially pain is under control or hypertension is under control. So the notes toward the end of the patient's stay ought to be a little more focused on the family education and the therapy changes that you're seeing with the patient. But early on, we definitely should be working still on taking care of the loose ends from a medical management standpoint, or new things that come up because they are doing more in the rehab setting than they were allowed to do in the acute care setting. Services are consistent with their diagnosis, need, and medical condition. One of the things that I spend most of my time doing as a consultant is matching up your payment on the provider side to the documentation in the chart. So I do a lot of that with you guys in terms of here's what you documented and here's what you billed. The same is true with the IRF-PI. Here's what you documented on the IRF-PI and here's what billed, and here's what you put in the chart. does that match? Sometimes with coding, one simple word can change the meaning. Coders aren't interpreters. They're not looking at your documentation and trying to figure out what you meant by that. They're looking at your documentation and they're putting numbers down that it would be a direct translation of what you said into an ICD-10 code. So sometimes what we're doing to treat a patient may not have the proper diagnosis to support it. One example of that, just to make it a little bit more clear, is dysphagia. That's a diagnosis. You might talk about the patient having swallowing problems and a speech therapist evaluating for swallowing problems, but if you don't call it dysphagia, then it doesn't get diagnosed. So you might have speech therapy services being provided that don't have anything to substantiate those services. We need to be very clear that what you're doing is being talked about in the record, not just being in your head. Also, the services need to follow the plan. So the role of the physician in this is to direct that plan. We should have a good, long, thorough problem list, what the patient's issues are and what we're going to do to address those issues, so that downstream those nurses and therapists who are taking care of those issues and documenting what they're doing to take care of the patient are backed up by that assessment and plan that was established by the physician. Services need to be reasonable and necessary. We certainly don't want to do things that are outside the scope of the patient's reason for being in rehab. One of the most surefire ways to make sure your costs exceed your reimbursement is to address things that are not reasonable and necessary during that hospitalization. They may be convenient, but if something is more reasonable to address on an outpatient basis, it should be addressed on an outpatient basis rather than muddying the waters during the inpatient rehab stay. And that's just a way to be financially prudent given our payment system makeup. We also need to show necessity, or can show necessity, by showing that the patient's making progress. We don't want them to be perfectly good as soon as they get there. They need to we need to show progress during their stay and address the things that are standing in the way of the patient progressing, and talk about what we're doing to reduce those barriers, especially in terms of medical management. Some of the key areas where we do this is pre-admission screening. That document is a standalone document. I should be able to look at any patient's pre-admission screening and understand exactly why they were admitted to inpatient rehab. I should see from a functional standpoint that they need it. I should see from a medical management standpoint that they need to be in inpatient rehab, that they have things going on, they have the ability to make progress, that we can set realistic goals for them, that they're below baseline from a functional level. Why am I telling you this? Because in a lot of cases, you guys are either doing consult for the sake of managing patients in acute care, or you're reviewing someone else's work. But let me remind you, you're putting your name on that document. So when you're approving that patient's admission into the rehab unit, I know a lot of you are probably going off of conversations you're having with the liaisons about the patient's case. You're looking at some of the hospital documentation that you have access to, but none of those things last in the patient's rehab record. The pre-admission screening does. So if there are errors in the pre-admission screening, if there's not enough information to justify why the patient is there in the pre-admission screening, then you need to remember your name is on the document. So if you're uncomfortable, send it back to the liaison for corrections. Then in the physician documentation, you're establishing justification for the admission through the admission assessment, through your daily documentation, and then your discharge documentation. The nursing documentation sets the nursing plan of care, which should address all of the items that are listed in your H&P assessment and plan. What is the nursing role in ensuring that the patients maintain stability? They also play a role in functional carryover. The therapy documentation has a plan of care that connects the functional deficits to the patient's medical conditions and notes progress and barriers. I'm going to go through a couple of the CMS requirements just because I want to be sure everybody is acutely aware, since one wrong signature date and time can ruin the entire record as far as payment goes. The role of the rehab physician that falls onto the shoulders of the doctor, not an extender, are now threefold. We just lost one of them last October, thankfully. A doctor must approve the patient's admission. So by signing the pre-admission screening, you approve that patient's admission. The time frame on that is within 48 hours prior to the patient being admitted. So if the patient's not here by the 48th hour, the liaison has to update the pre-admission screen to make sure the patient's still appropriate for admission, and the physician would need to sign it again. The one that went away is the 24-hour piece that required the post-admission physician evaluation to be completed within 24 hours of the patient's admission to rehab. And really, that document just added a couple of things to a typical H&P. CMS has since realized that a lot of this is covered in your pre-admission screening and your H&P and reiterated in the overall plan of care. So that separate document, the PAPE 24-hour requirement, has gone away. I want to caution you that most hospitals have a 24-hour requirement on the H&P completion. So you still have to timely get an assessment on the chart, but CMS auditors won't be looking for that necessarily. As an auditor and consultant for providers, I do look for that because it's in the policies and procedures, which means Joint Commission or whatever accreditation body is also looking for adherence to that. So you may have hospitals telling you, hey, your H&P was not on a timely manner, et cetera. That's why they're still monitoring it. The overall plan of care needs to be completed by the 4th day. It has to be signed by the rehab physician by the end of the 4th day. 3 weekly progress notes. So what Medicare says they're looking for in your progress notes, which we're going to talk about in more detail later, are both medical components and functional components. So 3 times a week, and lead the interdisciplinary team conference. Now, the entire claim can be denied if one of these pieces is missing. So as I mentioned, the post-admission physician eval is not required. H&P is. So what should go into an H&P? Summary of the patient's status upon admission. How did they look when they got there? You should be laying out their expected course of treatment. Describe the clinical rehab complications that place the patient at risk and what you plan to do to avoid them. So we're looking at actual active diagnoses. We're looking at things that the patient is at risk for. We should be describing adverse medical conditions that might be created because of the patient's medical comorbidities and rigors of the intensive rehab program, as well as methods that might be used to avoid them. And then predict the patient's functional goals to be achieved within the medical limitations of the patient. I didn't come up with this. This is Medicare speak. So if you're worried about having too many things in an assessment and plan, please stop worrying about that. It's more important that we have a good perspective and picture of what's going on with the patient, what's actively requiring management because of the other things we're doing with the patient in the inpatient rehab setting. What are we worried about? And what do we feel the patient's risks are? Not every one of these things is going to have an active plan to go with it beyond keep an eye on these things. But I would strongly encourage you to put those out there in terms of the assessment and plan. It allows for more comprehensive coding, which ultimately is going to get the provider paid adequately. And it's going to do a better job of establishing the medical necessity, explaining why it was reasonable and necessary to bring that patient into the hospital setting. CMS clarified that the hospital can determine whether or not a physician has adequate credentials or experience to be named a rehabilitation physician. That is a question I get asked a lot, especially in rural areas where it's hard to recruit PM&R physicians. Do you have to have PM&R residency and training? The answer is no. CMS doesn't care what the training is. The hospital has to or is able to establish those requirements. So what is CMS looking for? They're looking for in your documentation to make sure that you're showing that you know how to treat these patients. So they're looking for medical management and therapy treatments. Ideally, those both should be addressed in your plan of care. So your problem list or assessment shows the primary diagnosis. Primarily, why did you bring that patient here? What complications and coexisting conditions exist, including chronic conditions. Symptoms that require treatment. So do they have left neglect with that stroke? Do they have dysarthria with that stroke? Precautions, things you need to watch out for, additional rehab impairments or diagnoses, maybe things from their past medical history that are still impacting the stay in inpatient rehab, and anything that places them at risk for, or any preventative measures you need to be taking. In inpatient rehab, we worry about the patient's IGC, their impairment group code. That's the primary reason we brought them to rehab. PPS coordinators are the folks that are responsible for identifying which of the 21 codes they're going to use based on your documentation. The role of this physician is to clearly document where the patient's biggest deficits are. Most of the time it's pretty obvious, but then sometimes it's hard to tell. You've got a cardiac issue, a pulmonary issue, and just a general medical issue. What's the thing that they're most debilitated due to? And if you can help tease that out, if it's cardiac, if you want them on cardiac precautions, if their therapy plan needs to be tailored to cardiac or sternal precautions, make sure that gets the headline in your assessment and plan. If they've had a score of things that went on during their stay, that it started with an admission for, well, let's go with COVID, since we've seen so many issues around that are lingering issues or issues that have piled on after their initial admission. So they came in with a respiratory issue related to COVID, and then they had one thing after another happen. And ultimately now they've been bedridden for so long that you're concerned about a myopathy. It's really helpful to the folks coding the IRF-PI if you can tell the story of all the things that happened, but say to them, by virtue of putting it in #1 position on your problem list, this thing, this critical illness myopathy or this polyneuropathy is why they needed to come to rehab. Because after all of those things, they ended up with this diagnosis, and this diagnosis is what is going to make them progress slower than the other thing that brought them here. So that helps clear up the question mark of what is it we need to be focusing our time on, or how do we want to capture payment for the burden that's going to describe our time spent. The plan should support the medical necessity by describing what you're going to do to take care of the conditions. It should reinforce the decision to admit the patient, provide evidence of the complexity of the interdisciplinary program, list the interventions to be provided by each team member, and imply skill level required to provide such services. So as I mentioned, every item on your problem list may not have a plan. I expect you're going to have several things that you are including a plan for, because we are taking patients who haven't achieved medical stability yet. The overall plan of care, I cannot talk about this without tipping my hand and saying, I really don't see how this provides additional value to the care of the patient, but we are required in inpatient rehab to complete this 4-day document. Luckily, most of you are on an electronic medical record, so information's flowing into a form that just requires the physician's signature on it. If you read here what the intention behind this document was by CMS, I think they had a good goal. It just maybe not a lot of grounding in how we document and care for patients. But they felt that adding this document in 11 years ago now would make sure that high quality care was delivered to patients, because it gave us a chance to plan the patient's course of treatment and make sure it was coordinated. At this point, like I said, the goals blow in from therapy, usually some of the nursing care plan items, and then the physician, maybe even case management, pulling in discharge destination, length of stay, or maybe that's something the physician's providing and you guys are signing that document. It has to be signed by the end of the 4th day. These are the laundry list of items that are required. Because you're not handwriting that, I have it here for reference, but I don't think it's probably part of your day-to-day concern. Just sign it by the 4th day. And then we're moving on to the 3-time-a-week visits. The reason why 3 times a week was selected was because the idea in the mind of the CMS creators was that the patient should need to have physician intervention at least 3 times a week. That shows that the patient hasn't achieved stability if they need doctor visits at least 3 times a week. So at this point, it is still best practice and common practice that physicians are seeing patients each day of the week and often one time on the weekends. But at least 3 times a week, your notes should reflect assessment of the patient both medically and functionally, with an emphasis on the important interactions between the patient's medical and functional goals and progress, as well as modify the course of treatment as needed to maximize the patient's capacity to benefit from the rehab process. So they're looking at every note for what you're doing to manage the patient medically. And at least 3 notes a week should address functional updates, progress, participation, and any changes that you're recommending. So once again, the EMR has done a good job of helping you stay on top of that by pulling in therapy updates from different sections of the record. I believe best practice is still for you to reflect on the information that's pulled into the notes by saying something in your either subjective portion, in your assessment portion, in your plan portion of the progress note that indicates whether the patient's progress is as expected, is better than expected, is not going very well, and then what you're going to do to make adjustments accordingly. So you shouldn't just have it in your note. It should be a part of your assessment and your plan with the patient. And you're reflecting that by commenting on it in a note, in addition to what was pulled in. So it's redundant if what you're adding right now in your notes says walked 300 feet with PT. That's already in the PT note. What a better expression would be is walked 300 feet with PT. This is a significant progress or significant improvement over last week's performance. Or if you had, you're looking at that and saying, all right, so we tried Adderall to improve their level of alertness and focus, and look at the improvement it's having on their function. That's the kind of quality that we're looking for in the progress notes. Certainly, you're probably not going to see that much of a change or something that dramatic 3 times a week. But if it does happen, that's a great opportunity to talk about it. The other time that is a great opportunity to talk about the patient's progress is team conference day. You've just had a debrief with the therapists. So, what are you thinking? What do you want to work on now? How much longer do you feel like it's going to take to get the patient home? What are you dealing with family barriers to getting them ready to take the patient home? The other time a week, if you're at a loss for things to say, talk to the patient about how they feel they're doing and put a reflection of your conversation with the patient in about their functional progress and participation. So now I've given you team conference day, a conversation with the patient, and an update that ties the medical and the functional. You are welcome to have as many more notes on function as you can and will, but at least 3 times a week, make sure you're covering bases by doing more than just pulling the documentation in from another part of the chart. Modifications of the course of treatment. I mentioned this a little bit earlier. To reflect medical necessity, we want to show changes. I should be able to see medical decision-making or change every day. It's not always going to be medical change. I mentioned earlier, early in this day, you are going to have medical issues that you're talking about on a daily basis. So I would expect when I look at your notes from the first part of this day, medical issues should reflect that decision-making. Later in this day, the emphasis is going to be on family training and meeting the functional goals. So ultimately, there should be something new for you to comment on a daily basis. One of the ways that I've seen providers track this is by keeping a chronological list of what you're doing to manage the conditions. So some providers do it by going through problem by problem and putting a date with the entries they're making. Some of them would rather have the problem list and then a separate section to just put in the updates for the day-to-days. I personally like it better when it's by problem, but that's completely up to you and your style. Don't forget, when you're writing an order for a medication change, document why you made the change in the progress note. When you are ordering labs or when you're reviewing lab results, as those tie to a diagnosis, that's a good opportunity to put in why you're ordering labs or what the results of the labs were and how that's, what's going on with the diagnosis now. Same with ordering tests, why you ordered the test, what that test is going to do as far as advantages, hastening rehab, participation, and discharge. Any interaction with other professionals, it gives you an opportunity to show decision-making and adds to your note. And then the patient's functional gains, as discussed with them, are a nice addition to your notes as well. But ultimately, it's imperative. If you're billing at a moderate level, then there's got to be something going on with that patient. And stopping and thinking through what you're doing, I'm sure you can find something. It's not just about your time, but including your time or thinking about how much time you're spending is also a good way to help ground you with the note. And that's where, if you're documenting based on time, all of the interaction and the conversations with the patient are credited to you in terms of the billing code you can use. And you're substantiating the necessity, the medical necessity and reasonableness by documenting that special statement that I've gone over several times of how much time was spent in care coordination and counseling, and what topics were covered. I'm going to talk just a bit about 60% rule compliance, because I know that's also an important factor for inpatient rehab providers. We have been under the 60% rule since, I think, 2006 in its current form. I don't anticipate changes coming to this anytime soon. We had some hiccups when we went from ICD-9 to ICD-10 that seemed to have been ironed out. At this point, I'm going to go through some of these with you more from the perspective of how can you help the providers on the hospital side know what to be looking for in cases that they're evaluating for admission, but also then on your side of what do you need to be highlighting in the documentation to ensure that they are captured correctly in impairment group coding and ICD-10 coding that will support 60% rule compliance, since that is where the codes come from. Stroke patients are 60% rule compliant. This is new strokes, and it's patients who have had a prior stroke but are coming to rehab solely because they've had a decline in function that has exacerbated the stroke symptoms. So it may have been a different diagnosis that brought them to the hospital, but because of whatever the diagnosis was that brought them to the hospital, resulted in a decline of function, and now the patient's exhibiting more stroke symptoms or exacerbation of the symptoms of their prior stroke, more than they were before they came to the hospital, we can bring them back into inpatient rehab. We're still going to call them a stroke. We're going to identify that it's late effects of a stroke through the way we classify it in an admission class, and also the coding of it will be late effect stroke rather than indicating a new infarct or hemorrhage. Spinal cord injury patients are 60% rule compliant. We have traumatic spinal cord injuries in this group, as well as non-traumatic spinal cord injuries. The non-traumatic spinal cord injury patients sometimes are not 60% rule compliant. We have to be real careful with the spinal stenosis patients for a couple of reasons. One, it's hard to know which impairment group they go into, which we're going to select based on the symptoms they present with. And then if we're using a diagnosis like spinal stenosis, CMS has decided that's not specific enough to warrant classification as a 60% rule patient. So unless they have neurogenic claudication or myopathy or myelopathy, in addition, documented, which would code it differently, then those patients are going to fall into 40%. Our back surgery patients that are considered spinal cord patients are really classified into that impairment group based on their presentation, not necessarily based on their diagnosis or level of injury, which is kind of weird. A lot of times lumbar laminectomy patients don't have spinal cord involvement. And they may end up as an orthopedic admission into rehab, or if there's a nerve root issue as a neurological. But if they do have any even swelling that is causing any sort of compression, such that you see lower extremity weakness persisting after admission, after surgery, then we're going to classify that patient as a spinal cord injury patient. Other things that fall into the non-traumatic spinal cords would be like an abscess or a stroke in the spine, maybe even a non-surgical spine with spinal cord compression. Lots of things. It's hard to say that without giving you anything more specific, but congenital deformities are also 60% conditions. We don't see that very much in the adult population. Amputations of the lower extremity are counted in the 60% rule. Major multiple trauma, this is brain and spinal cord injuries, brain injuries with fractures or an amputation, spinal cord injuries with fractures and amputations. 2 or more fractures, as long as one of them is a lower extremity fracture, and any 2 injuries. I think that's a missed opportunity in a lot of cases, is listing all the problems that happened or all the injuries that happened after a patient's accident, and then highlighting what still requires care and management in the inpatient rehab setting. If we're dealing with contusions, lacerations, internal injuries, even hematomas that are causing pain issues, dislocations, all of those things are considered when we go to select the major multiple trauma category. So talk about what you're doing, and the people coming up with the right codes for that patient shouldn't have a hard time figuring out how to select an impairment group code. Fractures of the femur at the hip are compliant. There's a big fat question mark in my mind about acetabular fractures. In one of the lists, acetabular fractures are counted as 60% rule compliant, but because the Federal Register does not list pelvis, they list fracture of the femur at the hip, then I'm not sure that that would pass muster if you are having a CMS audit for your 60% rule compliance. Brain injury patients, both traumatic and non-traumatic, are 60% rule compliant. Neurological disorders such as MS, motor neuron disease, polyneuropathy, myopathies, muscular dystrophy, and Parkinson's are considered 60%. There are a lot more that fall into the neuro category as well. I did mention that back surgery patients with a nerve root issue may fall into neurological. That's actually not one of the 60% diagnoses for the neuro category because it goes into other neuro, but do look out for nerve root impingement or nerve root lesions that are causing symptoms and deficits post-surgery on the back. And if you're describing the symptoms as persistent, we're going to code them as a neuro case, which matters in terms of days and dollars, even though it's not 60% compliant. Burns fall into 60, also total hip and knee when the patient is over 85 years of age or have a BMI of 50 or more, or when they have bilateral replacements at the same during the same acute stay. This is my slide for what am I looking for, or what am I telling the PPS coordinators to look for when selecting an impairment group for post-back surgery patients. So the non-traumatic spinal cord patients, I'm looking for documented lower or upper extremity involvement, such as weakness or paresis. So when you're doing manual muscle testing on these back surgery patients, please do manual muscle testing on these back surgery patients. We're looking for weakness of 4-5 or lower in one or both limbs. That's the best we can do to suggest that there is still persistent lower or upper extremity involvement. Neurogenic bladder or bowel issues documented help support use of that category. And as I mentioned, if there's neurogenic claudication that you're documenting, or myelopathy, or spinal cord compression, these are more specific. These code more specifically than simple spinal stenosis, so that will help justify the 60% for those patients. For other neuro, if you see evidence of foot drop, radicular pain, sensory deficits, and or neurogenic bladder or bowel post-surgery, that justifies use of 3.9. If we don't see any of that, if the patient's just generally weak, or you're doing pain management post-surgery, and they have the functional need and medical need to be there, the last category we'd probably place these patients in is other ortho. The next thing I want to touch on as far as inpatient rehab coding goes is tiering comorbidities. This is, I'll take one step back and say our CMG for inpatient rehab, in case you're unfamiliar, is made up of the patient's impairment group code, the primary reason they're coming to rehab. The second thing that goes into the payment category is the patient's function. So the baseline scores for ADLs and their mobility goes into the CMG, indicates what you're going to get paid to take care of that patient. The last factor is whether or not they have a comorbidity that's requiring management during the stay that you're not already being compensated for in their impairment group. We have 3 levels. Tier 1 pays you the most extra, Tier 2 in middle, and Tier 3 the least extra, but it's still extra. Why are you getting this additional payment? You're getting this money because it's not considered typical care for a rehab patient in the selected impairment group to have to also manage these conditions. So they want to make sure you've got adequate resources to take care of that. The Tier 1 conditions are easy to remember: trach or recently decannulated with a healing stoma, dialysis, and paralysis of the vocal cords. It has to be stipulated as unilateral paralysis or bilateral paralysis or edema of the larynx. So when you've got a patient with a trach tube in, I'm sure you're not missing those. Don't forget the patients who have been recently decannulated. If they still have an open or healing stoma and you're even just doing dressing changes on it, that needs to be stated in your documentation in order for the coders to pull that information out. So status post-trach, decannulated on such and such a day, I see it all the time. What I don't see is status of care to that trach site. So please make a note that that's the important detail that gets the provider to that Tier 1 comorbidity. and gets the patient more days. The tier 2 conditions, it's a longer list. There are 18 conditions, but it's really made up of about 4 things: C. diff, Pseudomonas, dysphagia, and post-op malabsorption. We have a lot of different codes. You don't need to be worried about what's what and the numbers that go with them. With dysphagia, we need to know if it's what phase of dysphagia, but if you don't know, just calling it dysphagia will code out to unspecified, and we're happy with that. With C. diff and Pseudomonas, it's important that that makes its way into the progress notes. So remember when I said, once you've looked at the lab results, be sure you're reflecting on that in the progress notes. This is one of those times and it's really helpful to reflect that information in the progress notes so it doesn't get missed when the coders are reviewing the documentation. So once you have confirmation of the bug, put the bug in the progress notes. The tier 3s, very, 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 very long list. These are the top 30 conditions. Luckily, there's a lot of repetition, so I can kind of wrap it up with diabetes type 2 with any complication. Hyperglycemia, typically, to substantiate that, I'm looking for blood sugars that are spiking over 200 or a high A1C. For hypoglycemia, which is also on the list, I'm looking for blood sugars dropping below 70. If the patient's exhibiting signs of hyper or hypoglycemia, it doesn't really matter what their blood sugar levels are. Tell me that they're exhibiting signs and symptoms of hyper or hypoglycemia. That substantiates your diagnosis of that condition. Diabetes without complications, not on the tier 3 list. Diabetes with any complication does show up on that tier 3 list. It can be chronic kidney disease, it can be polyneuropathy, neuropathy, peripheral artery disease, ocular issues. Let me cheat and go ahead and see what's on the other slide. Foot ulcers, anything that diabetes has caused, and there's a code for it, will fall on the tier 3 list. Active acute kidney failure, so you're treating the patient's acute kidney failure. Morbid obesity, which is a BMI of 40 or more, or 35 or more with an obesity-related condition, which is considered to be hypertension, diabetes, or obstructive sleep apnea. Hypertensive heart and chronic kidney disease, as long as you're documenting hypertension and the chronic kidney disease, the coders will match those 2 conditions into one ICD-10 code. Congestive heart failure, if you know the type, diastolic or systolic. Hemiplegia outside of a stroke codes differently when it's stroke related. So with your spinal cord tumor patients or a brain injury patient, please be sure to state not just weakness, but hemiplegia or hemiparesis for it to code out into the tier 3. Pneumonia that you're treating. Pleural effusions that are being treated. Acute respiratory failure, we should also see documentation for ongoing treatment from the patient's acute respiratory failure. Was probably diagnosed acutely, but if they still need higher levels of oxygen, antibiotics, respiratory care, those are considered to be active treatments. COVID-19, if you're treating the effects of COVID-19, we can count that as an actively treated condition. Pulmonary embolism, cellulitis, sepsis. There's another odd one, non-specific abnormal findings of lung field. That typically, I see that with lung nodules. So those are the top 30. Like I said, there are plenty of others that make the list, but make sure you keep those handy. Just using the right terminology is the key to getting the right payment. So really just to wrap up, the medical necessity is the most important thing in the documentation. It supersedes your coding requirements and your coverage criteria. You need to say enough in your notes to show medical necessity. The second part of that we use medical or physician documentation for is coding. To get accurate reimbursement and length of stay and to ensure 60% rule compliance, your documentation is paramount. And then we're using your documentation for billing. So your professional services and E&M codes are absolutely dependent on the quality of the documentation you're producing. Obviously, your medical decision-making piece of that is the most critical element that supports the need for close medical supervision. It supports active medical management by connecting your subjective and objective to the assessment and your assessment to the plan. It should be describing why you're doing this and why not that. This is how I got from here at admission to there at discharge with any certain condition. So I used my entire hour. I'm going to turn my slideshow off. First of all, feel free to contact me with any questions that you have outside of this time on the webinar. I'm happy to be a resource for you guys. Every time I do an audit and have a conversation with one of you, I do encourage you to keep my contact information, reach out if you have questions. That's always true. I'll be happy if you have time to stay on. I'll be happy to address any questions that you have now.
Thanks so much, Lisa. That was really comprehensive. And one can never hear this information too much or enough. It's just so important, and we really appreciate that. Any questions? You can raise your hand or unmute. You all did really well. That was a solid hour of education. Yeah. It was great, really great. So if there's any questions, please contact me or Lisa as well. And if anybody has any questions about ALJs and wants to learn a little bit about how doing them effectively and efficiently, you can contact me directly, and then we'll have a one-on-one discussion about the ALJs for those of you that are doing them at this point in time. So. Good. Well, anyways, everyone have a great weekend. Thanks for your time, and enjoy hopefully a couple of days away from the hospitals. Thanks, everyone.